Yeah, you can start.
Okay.
Hello.
So
Yeah.
So good afternoon. That my topic is current concepts and modalities in the following up of neovascular AMD patient. So we have been. The slide is not. Yeah. So we have understood very well that the anti-VEGF therapy has brought out a revolutionary change in the management of neovascular AMD. But still, we don't have the final answer for an important question as to what is the optimal interval for following up these patients. Of course, when we follow them frequently, as like on a monthly basis, we can prevent a progression, but this does involve a lot of treatment burden to the patient, and sometimes we might actually be over treating some of the patients. If you extend the follow-up gap or even the treatment gap, then there is a risk of recurrence and progression. So in short, what we see is the burden of the disease has now turned into a burden of care. So if we have a monitoring system which will provide us some inter-visit information that will help us to detect the progression or recurrence as soon as it happens, and this will enable us to provide a personalized disease management. It will help to reduce both under-treatment and treatment burden at the same time maintaining the visual acuity. It will also help to improve the compliance with the really needed injections. And this will also help us to know the appropriate dosing interval of the newer drugs that are coming up with longer duration of action. So it is not only important to monitor the treated eye, we should also be taking care of the fellow eye in AMD patients, because AMD is basically a bilateral disease, though it starts manifesting in one eye first in the majority of patients. But whenever you have a CNV in one eye, it is a strong risk factor for CNV in the fellow eye. And usually the fellow eye is involved by 4 years in at least 27% of patients, and if not treated, it can lead on to legal blindness. And the most important predictors of outcome are the initial visual acuity, the size of CNV, and the duration of CNV. So that means early detection and treatment is very critical. So this is from the CAT trial, which has shown that if the initial lesion size is small or the initial visual acuity is better, the final treatment outcome is also better. And this effective intervention not only preserves the patient vision, but it also helps to improve his independence and reduce overall societal cost. But unfortunately, what we see is even in the clinical trials, there's a delay of about more than 7 months before the enrollment of the fellow eye. And by that time, the lesion has already grown to the size of 4,000 microns. So what is the cause of this delay? Sometimes the patient will not notice any visual changes, or they don't have any visual changes because of the compensatory mechanism, or the lesion may be extrafoveal in location. Some patients may not be really familiar with the symptoms, and they think it is just part of the aging changes, and they are less aware that this is something which can potentially lead on to irreversible blindness. They think that it will resolve on its own. They don't want to be a burden to the family, and travel barriers, all the more relevant today, the presence of comorbidities, and even the inability of the caregivers to bring the patient for appointments. So it is important that patient education should be directed not only to increase awareness among patients, but also to the caregivers. And at each office visit, we should emphasize the need for regular monitoring. So how can we improve on this? Currently, what we are doing is clinic-based monitoring, where patients come for pre-scheduled visits. Whenever they notice a new symptom, they might come for additional visits in between, and maybe motivated patients will keep monitoring their vision with Amsler in between. And in the clinic, we check the visual acuity, do a fundus examination, followed by the imaging modalities, of which most important is OCT. But this has a lot of limitations, right from cost, the availability, and it requires trained person. All these efforts are needed. But in spite of all this, we are missing a lot of information in between the visits, which can lead to poor visual outcome in the long term. So how do we improve this? We have to incorporate home-based monitoring so that the patient is having a more active role and he feels responsible for monitoring his own vision. And what are the parameters that we can monitor? It has been shown by all the major studies that the two important factors that decide the outcome is, one is the visual acuity and the other is the CNV lesion size. So definitely the parameters that we have to monitor are the visual function, and maybe if we have an option of a home OCT, which gives us the structural changes that is happening in the retina in between his appointments. So in the visual function, conventionally, we have always been checking the visual acuity, But we all know that many times we see patients where the visual acuity is maintained, but the condition is actually deteriorating. That is because in visual acuity, we are actually testing the cone function and we are only checking only a very restricted foveal area. But in AMD, actually, the rods are affected earlier than cones, and the decline in the rods also happen more rapidly. So it is important that we incorporate other parameters of visual function when you are monitoring these patients, and I'll be explaining this in a little more detail. So this is something that is going to happen in the future. Patient will be having an active role in monitoring his vision by various devices or a home OCT once it is available. And with the availability of all the internet facilities and cloud systems, the information will be uploaded to the cloud, where with the use of artificial intelligence, raw data analysis will be done and alert will be sent to both the patient and the physician, and the patient can come for an appointment for further management. For that, we need to have devices which are patient friendly, easy for the patient to use. It should be tolerable to environmental factors like adjusting the distance, the lighting, etc. should be practical. It should have frequent change of the test target, otherwise the patient will memorize that and will lead to a false result. It should be relatively unaffected by aging. It should have a provision for remote monitoring, and most important, it should be affordable for our population. So we will look into some of these tools for monitoring. Historically, the most important is Amsler grid, which has already been touched upon in the earlier talk. It is very widely available, easier to use. You can use both at clinic as well as at home. But the problem is it is very variable in sensitivity. You cannot quantify it, and so it is not a very ideal monitoring tool. And because of the compensatory mechanisms of the brain, sometimes you miss the metamorphosia. So this false negative result can even lead to a delay in the treatment. A little more better parameter would be monitoring the near visual acuity, because it is found that there is a definite reduction in the reading rate before actually the visual acuity drops. And this can be assessed by checking with the near vision charts. But again, its efficacy in monitoring has not been very well studied. And also there is a problem of compliance unless a patient is highly self-motivated and keep using these devices regularly. And usually these comes as chart-based devices, so there is also the difficulty in maintaining the charts. It can get torn, the letters can get fade away. So now we have, in this digital era, we have all these testing possible with the use of various smartphone apps, but unfortunately the majority of these are not standardized or validated for monitoring in AMD. Now recently a new app that is known as a checkup app has been studied, and it is validated for both monitoring AMD and diabetic retinopathy. So this is an app which can be downloaded into your smartphone. It gives a patient instructions of how to go about the test, as to close his eye, use his glasses, and then he's presented with both near visual acuity and Amsler testing can be done using this app. And patient will be presented with a series of near visual acuity charts, one letter at a time, with progressively decrease in size. What the patient has to do is, if he can identify the letter, he has to match it with the corresponding letter in the larger box shown at the bottom. And depending on the patient's response, the scoring is done, and based on that, you can assess whether there is a progression of the disease. And this is found to have good agreement with the in-clinic testing, and it can be used as a reliable tool for both clinic as well as in the home settings. Contrast sensitivity is something, though very useful, it is often ignored. Contrast sensitivity is the ability to recognize small difference between the luminance of an object and background. And this is important because the contrast sensitivity response depends on a pooled response from the retinal neurons. And in AMD, there is a loss of this neuronal pool. So contrast sensitivity is decreased in all stages of AMD. It can monitor the slow vision loss, which happens in AMD, much better than a visual acuity. But despite all this, it is infrequently used, maybe because of the lack of familiarity, time constraints, etc. And one of the common chart that we use for testing the contrast sensitivity is the Pelley-Robson contrast sensitivity chart. And this is not usually widely available. So this chart actually has a series of letters. The size of the letter remains the same, but it is the brightness or the luminance that keeps decreasing, and finally it becomes almost the same as the background, and the patient won't be able to differentiate it. So this is which is done in contrast sensitivity. But maybe now we have this option also incorporated into a smartphone system, and this is known as a peak contrasensitivity, and which is delivered on an Android-based platform. This uses the tumbling e-chart. One letter is presented at a time to avoid the crowding phenomenon, and a patient's response is recorded and a score is given. Though it has been validated for community screening, it is not yet studied for AMD. Maybe this can be an option in the future. I did mention about that visual acuity alone is not a reliable parameter. A more sensitive indicator would be hyperacuity. Hyperacuity means you have to discern a subtle misalignment of an object. This is because when you show, as you can show this is a stimuli that is used in hyperacuity. It includes series of vertical or horizontal lines which is small misalignment, and this stimulus is projected onto the macula. And this misalignment is perceived by the patient, and this is recorded by the PHP. What happens in AMD is whenever there is a submacular detachment or a pigment epithelial detachment, there is a shift in the position of the photoreceptors, and this perceived shift in the image, which we anatomically correlate as metamorphopsia, is what being studied in the hyperacuity perimetry. It is very sensitive for detecting recent onset CNV, and it is also very specific in differentiating it from intermediate AMD. And moreover, this testing is resistant to image degradation, which can occur due to media opacities like cataract, and the threshold is not affected significantly with aging. But the current devices or the earlier devices were basically suitable only for clinic-based testing, and it was quite expensive. So now, with a lot of innovative ideas, a new device has been innovated, and this is known as a Notal Home device, which is available for monitoring at home, and this is by the Notal Vision Israel. It has a peculiar design, and which is very ergonomically designed for the patient. And the target that is shown is either a vertical or a horizontal line with a small distortion. Patient has to look at the center dot, and the distortion that is noticed where and when it happens has to be recorded with the help of the mouse, which is provided with the equipment. This is already FDA approved, and patient is asked to use it daily for at least few minutes per eye. First, you have to establish a baseline, and whenever a significant change occurs from the baseline, an alert is sent to the physician as well as to the patient to schedule the next appointment. And this device has been evaluated in a randomized controlled trial, which is known as the home monitoring of the eye study, that is a home study. The patients were having either bilateral large drusen or large drusen in one eye and advanced AMD in the fellow eye, and they were randomized into two arms. One arm is a standard of care, where the patients just had to follow the specific instructions given by the physician for self-monitoring at home. Whereas in the other arm, apart from standard of care, the patients were also instructed how to use this device. And we can see that the use of the device did help to pick up a much higher number of CNVs, and the average decline in the visual acuity was much lesser, and the number of percentage of patients who maintained a good visual acuity was much better. So incorporating such devices definitely improves the home monitoring of these patients, but as of now, the only limitation is the high cost. Another type of hyperacuity is the shape discrimination hyperacuity, which involves discrimination of shapes, and this requires global integration, which is again significantly affected in AMD. So here the target is either perfect circles or circles with slight distortion. These are called as radial frequency patterns, and the patient has to distinguish this abnormality. And now this also is available on a smartphone-based system. This is known as a MyVision Track, and this is the first FDA-approved app for use in monitoring in the AMD patients. And this has its patent algorithm for automated analysis, and it's found to be quite useful for detecting the progression from early to advanced disease. So the patient is shown a series of stimuli, and the patient has to identify the odd figure, and with the progressive stimuli, the difficulty level increases, and this is useful in monitoring the patient. But it can be challenging for patients with poor head, eye, and hand control or dexterity problems, etc. So the newer devices are trying to create a voice control instead of using the hand for giving the option. Now we move on to some of the perimetric methods. Perimetry, basically we try to detect the scotoma, whether relative or absolute. And these defects in the central visual field is very important in AMD. But the conventional static perimetry is time consuming and it is not easy for the elderly patients with significant visual field defects. A better option would be the noise field or the entoptic perimetry, which gives a quick assessment of the entire visual field. Here the stimulus is a screen which shows randomly flickering black and white dots at high frequency. Patient has to fixate on the central dot and any abnormality in the background noise. This can be a darker area or a lighter area or where the motion frequency is reduced, and that has to be noted. And it is found to have good sensitivity and specificity for AMD. This because it can overcome the compensatory mechanisms of the brain. So wherever there is a scotoma, because of the stark contrast with the background, it is immediately detected by the patient. But it's not readily available. And now this also is available on a smartphone-based system. This is the various stimuli that is available with increasing in size, and you can not only have black and white, you can have blue, yellow, red, green, etc. This because this was initially developed for monitoring the glaucomatous field loss. And whenever the patient notices a scotoma, it is marked on the touch screen. So as of now, it is being studied for glaucoma, but AMD can be a potential target. Another type of perimetry which is very useful is the microperimetry. This is a visual function test to map point-wise retinal sensitivity. So at every point, you can correlate the function, that is the sensitivity, with the structure. This is because it is a much superior indicator, because here not only you're studying the exact fovea, you're studying a larger area. This includes a parafoveal area also, which has a higher density of the rods. And as I mentioned already, the rods degenerate faster and earlier than the cones in AMD. And you can do this testing in mesopic conditions, which is actually more similar to the real world scenario. We can see that many of our patients, though they have a good visual acuity, they find it difficult to perform many of the daily tasks, especially in dim illumination. So to assess all these aspects, microperimetry is very useful, but it requires fixation accuracy and some cooperation, and the formal perimetry is, as of now, only clinic based. Now, again, we have the same procedure which can be done using a smartphone by using what is known as a PsyPad platform. This is an open access platform which enables all kinds of visual psychophysics research. And in here, any stimuli can be presented as a pre-computed PNG image file. So this is how it works. Patient has to log in. Initially, it will show an instruction screen. Patient has to follow all the instructions that is given. And this is a stimuli. So patient has to fixate at the central cross. And these are the 12 locations that is tested, 4 points within the 1 degree and another 8 points within 2 degrees. So, and this circular stimulus against a uniform dark background is similar to the Goldman size 3 stimulus. So when the patient is presented with any of these circles at random location, and if the patient is able to perceive that, he has to press on the square button, which is given at the bottom right corner. So the patient's response is recorded, a score is given, and it is analyzed. And this is found to have good agreement with clinic-based testing. And what they did is they kept on giving weekly reminders to the patient through SMS, and that helped to improve the compliance also. Yet another form of perimetry is a RareBit perimetry, which is not very familiar for us. As you can see, this is a point which again I want to stress upon in the monitoring the visual function in AMD, that conventional visual acuity testing is not enough because it has a large margin of error. I'll show you this example. So this is an image of the digit 5. Even if you take a lot of information from this digit, you can still read it. It is still legible. Finally, it can be reduced to the minimum number of dots. So a person with a normal vision will still be able to read this, but a person with AMD with defective vision will need more number of dots to appreciate the outline of this digit. And it is this principle that is used in RareBit perimetry. So it utilizes this combination of minuscule test dots, which are presented to the patient for a brief period of time. Here, the size of each dot is something like thousands of a millimeter, so it is very sensitive to detect the change even in a single photoreceptor. So such multiple RareBit, or known as multibit, is what is being used in this study, and you use combination of several RareBits to form digits. So unlike in the visual acuity chart where the size of the digit progressively decreases, here the size remains constant, but the number of RareBits keeps increasing. So if the patient has good vision, he can even appreciate this digit But as the visual impairment increases, they need more rare bits per segment to identify the digit. And this digit is randomly presented anywhere on the screen. So they really don't need to have a good fixation also, which is another advantage in AMD patients. So as I said earlier, when you're testing the visual acuity, we are giving a target which has overload of information. And you are actually testing only a small restricted area close to the fixation. Whereas in the multi-bit testing, you are minimizing the information in the target, but we are employing testing a larger area. So definitely this is a superior method of assessing the visual dysfunction in AMD patients. And this has again been proved in the studies. So this is how the patient starts with the screen, instruction screen, and then the digits are presented in pairs, 2 at a time, and the response is noted and a score is given. So these are the various visual functions that can be incorporated in home monitoring. And now with the availability of the new generation smartphones and tablets, it's not too far that we can also start doing these things for our patients. Now we come to yet another aspect of home monitoring, where we are not just trying to assess a function, but the structural changes in the retina. And the importance of OCT has already been very well explained in the previous talks. But is it possible to incorporate is it possible to get a home OCT monitoring? Yes, in the near future. And this has already been studied in the Western countries. So at home monitoring is going to come very soon, hopefully. This will help us to catch and treat the wet days as soon as it happens by providing the patient and physician with a unique intervisit disease knowledge. It has a lot of benefits because it avoids under-treatment. At the same time, it reduces treatment burden, reduces the cost, and improves the satisfaction. And this definitely has a lot of relevance in the current pandemic situation. There are a few prototypes that have been studied. One of the first introduced one is a Notal Home OCT by Notal Vision, which is the same company that has introduced a 4C home device. It is a compact spectral domain OCT, which is self-operated by the patient, and it is integrated with an AI known as a Notal OCT analyzer. The patient has to use this device, and the scanning is done involving the central 10 degrees 88B scans with 34 micron spacing. It is found to be sensitive to detect even sub-nanoliter volumes of fluid, and it generates a fluid map. This is the kind of print that you get. This is a scan from the Heidelberg, and this is a scan from the Notal OCT. You can see it's quite comparable, and it's quite fast, and the patient is also able to understand how to do it fast with just a 2-minute video tutorial. And this has already received breakthrough device designation by FDA in 2018, but other validation and software is still going on. Another home OCT is the SELFF OCT, that is self-examination, low-cost, full-field OCT. Here, the device has been like really improvised. It's something like a handheld device. And this was achieved by cutting down the device complexity. They avoided all the costly equipments like spectrometer, tunable laser, etc. And it was made into a very simple, usable design. It has a fixation target which guides the patient for correct alignment. It is an adjustable knob for dioptric adjustment, so even emmetropia correction is possible. So patient has to look into the target, align, and then press on a button and the scanning will start. First, an overview scan is done to locate the ROP, and then a series of 5 detailed scans is done, and the whole process is over within a matter of 10 seconds. And this is the report that has been generated from the SELFF OCT. It's quite comparable to that of the Heidelberg. But the only limitation as of now is because of the increased scattering, the visibility of the structures below the RP is very poor, and the authors are trying to work on it and to improve in the next generation of this device. Another prototype for home OCT is a SPAS OCT, which is again an at-home device. Here, the patient has to keep his head in a unique inclined position. This helps to give more stability and reduce the motion artifact, and a very less dense scanning pattern is used. This helps to reduce the size of instrument and also enable to get very fast scanning. And this is the OCT image from a SPAS OCT in comparison to the Heidelberg system. And it is found to have good consistency and reproducibility. So this is just a comparison of various home OCT devices, and we can see basically all try to scan a small area, and the resolution also may be a little limited, but it's still giving enough information for monitoring the treatment, because this is not intended for diagnosis, it's basically for monitoring, and it's all quite fast, and success rate also has been found to be quite good. So to conclude, several promising technologies are being developed for monitoring in neovascular AMD. Home study has validated the superiority of home monitoring devices over the standard of care in early detection and minimizing visual loss. Monitoring of visual function should include hyperacuity and perimetry, which are more sensitive than visual acuity testing in AMD. Smartphones and tablets can serve as useful platforms for these novel self-dedicated tests. And definitely our next generation of AMD patients are also going to be quite familiar with the use of these gadgets. It is important to integrate this with AI software for automated analysis and remote monitoring. And the last thing, or the most important, would be the home OCT diagnostics, which can entirely change the way that we are monitoring and treating our patients. It's also important to modify the physician's workflow and the training to incorporate these new devices. And this has increased relevance and desirability in the current COVID-19 situation and even beyond. Thank you.
Thank you, Dr. Lekha. That was